work on the shop floor doing mobiles and your portables. They've done 3 years of radiography degree. They can then move on to become an advanced practitioner. So these are radiographers who just do chest reporting or MSK reporting, and then you can advance further into consultant post. So that's just a bit of a breakdown of the 4-tier structure within radiography. And you've probably seen it throughout the wards now as well, with advanced clinical practitioners on the wards. So it seems to be following suit, and there's becoming more and more of us. So what I'm going to do today is I just wanted to give you a presentation on chest x-rays, how to interpret it, and what to be looking for in chest x-rays. I want to give you my system of looking at a chest x-ray. Now, I'm sure that on the wards, people have been saying that this is how I do it. I do an ABC approach, or I do a DCA report approach. There's all sorts of different ones out there. So what I'll do is I'll show you the way I look at them. So you never know, you might pick something up new that I go through that somebody else doesn't. So you can just come up with your own system. And then what I thought I'd do is I'd have a look at some chest x-rays where we can do versus cases. So for example, air space disease versus interstitial disease, bulla versus pneumothorax, and things like that, just so you can get an appreciation. It's very difficult to show you the whole range of pathology you're going to see on a chest x-ray, but if I can give you them sort of fundamental theories underlying chest x-rays on how you can sort of figure out what's going on a chest x-ray. And then at the end of it, I'm going to go through 11 chest x-rays with you, so that'll be a bit more interactive then, and we can go through and see what we all think together. Okay, completely informal, so at any point, just if you want to ask a question, just shout out. If there's any of you guys on the chat who want to just drop a question, just please feel free to drop it whenever. So I thought a good starting point as you're a radiology society is to look at the fundamentals of chest reporting. It's only a very brief 2 slides, but it's good just to have an understanding of it now. To be honest, this isn't really applicable anymore because we have CT, we'll understand why in a second. So has anyone heard of the silhouette sign? No? So the silhouette sign, it's a fundamental theory in chest x-ray interpretation. Now it's a bit of a misnomer because you're not actually looking for the presence of a silhouette, you're looking for the absence of a silhouette. So chest x-ray interpretation, it's all based around densities. So you've got the heart, which is a soft tissue water density, so it's very bright on x-ray. You've got lungs, which are filled with air, which is black on x-ray. So the reason you can see a sharp cardiac outline is because you've got that difference in contrast between the dense heart and the black lung. So when you put drastic differences of contrast together, you can clearly see it. Now, when you start to put two similar densities next to each other, then margins, then interfaces become blurred and you lose the interfaces. So that's a silhouette sign. So the examples here on screen is that you've got a test tube, and in the test tube they put a piece of metal, they then put some water in it, and you can see the meniscus there. I'm not sure how well that projects on the screens for the online people. Then put some fat in the test tube, and then the rest of it was just filled with air. Now, can you see how you can see the different interfaces between them 4? Now, so when you put water next to air, you get a clearly defined margin between the 2. So this is like your heart next to lung, you get a really crisp border. Now, when you put water, so soft tissue, next to soft tissue, you'll lose that margin altogether. This is silhouette sign. So for this example here, if you had the heart and then you had some consolidation in the lingular or the middle lobe, which abuts the heart, you lose it completely. So it's basically good to know because it allows you to locate where pathology lies in the chest. Now, like I said, it's a bit irrelevant nowadays because we do CTs. So we don't need to actually formulate a report that says there is a cancer in the apical segment of the left upper lobe or anything like that. We can just say there's an apical tumour and it's going to have a CT scan anyway. So, but it's just good as a radiology society just to have an understanding of how chest x-ray interpretation started. So one test they did regarding the silhouette sign is they had 2 boxes, one anterior box and one posterior box. Now in the anterior box, they put a heart-shaped item, and in the posterior box, they put a descending aorta, because this is an anterior structure and this is a posterior structure. So when they took the x-ray, this is the image that was shown. So you've got a clear heart border, and then you can clearly see the descending thoracic aorta. Now, the reason you can see the anterior and the posterior structures clearly is because you've got an air gap between the 2. So that air gap creates that interface. Does that make sense? So what they then did is in the anterior box, they poured some water. So the water matches the density of the heart. And then can you see how you've now lost that border completely. You can no longer visualize that right heart border or the left heart border, but you can clearly see that descending thoracic aorta because of the air gap between the two. Similarly, you pour the water in the posterior box, and then what's happened now, you lose that posterior interface, but that anterior heart shallow you can still see. So it is just good fundamental knowledge to have. So like I said, just a whistle-stop tour on the silhouette side. So what I'm going to do now is I'm going to move on to a systematic review. This is my systematic review. As I said earlier on, there are multiple ways. When you read the textbooks, a lot of them talk about the ABC. You'll then look online and there'll be an ABCDD. But then some will say there's also it does not matter what system you use to look at a chest X-ray, as long as you use the same system every single time you look at a chest X-ray. Yes, in the early stages, it seems really tedious. You've got to go through every single thing. But the more and more you do it, the quicker and quicker it gets. Because ideally, what you're trying to do with chest X-rays is you want to see a vast amount of chest X-rays to basically ingrain into your head what is a normal appearance of a chest X-ray. Once you have that normal appearance of a chest X-ray stuck in your head, any abnormalities do start to jump out at you, and you get quicker and quicker at it. So all I can say with chest X-rays is look at them as much as you possibly can, because the more and more you do, the better and better you get. One of our consultants here at ELHT says that in order to become truly competent in chest X-ray reporting and maintaining it, you need to report in 10,000 a year. So you can see how many you need to be looking at. You guys as well, particularly on the ward, you're going to be perfectly placed at doing this, because you can just be looking at not only your own patients, but you can be looking at all the other patients. You can open the CXR UniView and you can just have a day list and just flick through them all and just get your eyes on what's normal. And then you're going to have the reports there as well to back it up. So what I always advocate as well is don't look at the report straight away, because it kind of makes you biased to what you're looking at. Have a look at the chest X-ray first, try and make your own decision on it, and then use that report as reassurance to what you're thinking is accurate. And if it's not accurate, you learn from it. So, looking at a chest X-ray, the first thing you want to do is look at the whole chest X-ray. So when you're looking at this, you want to be looking at the quality of the chest X-ray. So first things first, you need to make sure, is it rotated? Because if that chest X-ray is rotated, it can really exaggerate certain structures. So, for example, if you rotate chest X-ray, your hyaline can look bigger, and that can be misinterpreted as lymphadenopathy or a hyotumour or anything like that. It can also make your heart look bigger because you're catching it at different angles, so it can actually look like they've got cardiomegaly and they may not do. There are a lot of factors on chest X-rays that can be exaggerated by rotation. The other thing you want to be looking at, when you're looking at to determine whether a chest X-ray is rotated, you want to look at the spinous processes. So you want to be looking at the spinous processes, a slap bang in the middle of the X-ray, and then you want to be looking at the distance from the spinous process to the sternoclavicular joint. If that is equidistant, then that chest X-ray is perfectly straight. Yes, you don't have to be bang on 1 centimetre, 1 centimetre. It could be 2 centimetres, 1 centimetre. We'll still class that as straight, because some people it's really difficult to get them straight. But if there's a wild difference between the two, then yes, it is going to exaggerate things. So it's one thing to keep an eye out for. The other thing you need to be looking at is the scapula. So when we do chest X-rays, we always prefer to do them PA. Now the reason for this is one, because of the magnification. You don't get any magnification on the heart when you do a PA chest X-ray because the structure is close to the detector. Whereas if the structure is further away from the detector, you get what's called geometrical unsharpness and you get magnification. So I can actually draw it on here. So if this is your detector, you get your patient stood up right there, the heart is anterior structure, your X-ray tube is here. So when your X-rays come out, they come out from a focal position on the tube. So as it comes out like this, they come out and the bleed past, they don't come out straight. So you can see, so that is how big the heart is going to be on a PA chest X-ray. Now, conversely, if you've got your detector like that and you've got your patient's AP, so whether that's a portable or we can't get off bed, we can't sit up or anything, you've got your heart here, and you've got your detector and your tube in the exact same place. You then say the bleed rates from the focal points, that will actually be larger. So that's how magnification works in a nutshell. Now, the other reason we try to do PA is it's much easier to get scapula out of the way. Now, scapula overlying the lung fields can mimic pathology. I've seen 1 or 2 cases now where within radiology ourselves, it's actually been reported as a pleural-based mass. And then when they've done CT scan, there's nothing there. And when you actually look at the chest X-ray in hindsight, it's actually just the tip of the scapula here that's just overlying the chest wall. It can be very difficult. It is really important that we try and get the PA whenever we can and get them scapula out of the way. Yes, we do have techniques for AP chest X-rays to get them out of the way, but in some patients you can imagine it's quite difficult. Now you also need to look at whether the chest X-ray is lordotic or kyphotic. So is the patient leant back or is the patient leant forward? Some situations you can't avoid it. If a patient's got a severe kyphosis, there's no way you're going to be able to get the chin from overlying the apices. But if the patient is led back, then it can bring diaphragms up, it can make lung volumes look smaller, it can exaggerate the appearance of the highlight, it can make your heart look bigger. So we always try to get them. So what you've got to do when you guys are looking at chest X-rays, you've got to assess that chest X-ray first, make sure that it's a good quality chest X-ray before you start making a diagnosis on it. The other thing to look at as well is the exposure factors of a chest X-ray. So all I can say to you guys is when you look at a chest X-ray, can you see the ribs behind the heart? That's the easiest way to make sure that it's a good exposure. If you can see the ribs here behind heart, you know that's had a good exposure. Any questions on that? So next, like I said, my system of systematic review of chest X-ray, I call it the inside-out method. So instead of doing ABCs, I work in the centre and I work out towards the peripheries of the chest X-ray. Now, when I started off chest X-ray reporting, I actually started on the outside of the chest and worked my way in. And the reason for that is because I was an MSK reporter initially, so I was more comfortable looking at the shoulder girdles, the clavicles, and then working into the chest. But as I become more and more confident, it changes. So like I said, even if you guys use the ABC method at the moment and you decide, actually, I find it this way easier, just change it. As long as you use that same method every single time. So where I start is I start at the heart. So I look at the heart. And when I'm looking at the heart, you want to be checking if there's any cardiomegaly, obviously. So you want to be looking, is the chest, is the heart 50% of the full cardiothoracic ratio? The next thing you want to be looking at the heart is the shape of it. So you might have seen the chest X-rays, the heart looks triangular. So you sometimes see it coming extending out right down here. Now, a lot of the times these are fat pads next to the heart, so they can be safely ignored. I might have a case of it later on, which I can show you. But the other thing you want to look for is, does the heart look globular? So does anyone know what a globular heart can indicate on a chest X-ray? Exactly. So yeah, so are you getting all that effusion, that water accumulation around the heart? So that's another thing you want to be looking at. Now also, when you get a pericardial effusion, what else would happen to the heart silhouette? If you're thinking you've got your normal heart structure, but then you put in more fluid around the heart. So what's going to happen to the X-rays? So you don't, because the pericardial effusion contains the cardiac site, it's not going to lose any definition because you've still got the normal dark lung next to it. What actually happens is the heart becomes denser, it becomes whiter on the X-ray. Now the reason for that is just to do with the physics of X-rays. I'm not sure how much you guys know about this, but basically, anything that's whiter on a chest X-ray means absorbing more X-rays. More X-rays aren't getting through the patient onto the detector. So if you think there's nothing to attenuate the X-rays, it goes straight through the patient and hits the detector. But when you put fluid around another structure, or you put cancer around the hilum, that mass or fluid is going to absorb more X-rays, so it becomes whiter on the chest X-ray. So use it loosely because also exposure. If you don't give enough X-rays, it's also going to look a bit whiter. But it is a good tip. If you see like the globular shaped heart and you see it's a bit denser, then you've got to be suspecting that they have got a pericardial effusion. So once I've assessed the heart, I then work my way up the mediastinum. So the next structures I then look at is the hilum. So you see your hilum structures outlined here. So 3 rules for your hilum. So position of the hilum. Does anyone know which should be higher, your left or your right hilum? Yes. So Sorry, so your right is lower. Sorry. So your left is higher, your right is lower. Now, anyone know what the reason for that is? No. Vessels? Vessels? No. Trickier. And then it's a bit trickier than this. What is wrong? So what happens when you make pulmonary arteries? On the left, what happens? It comes up and it loops over the top of the bronchus and comes down behind it. But actually on the right, what happens is it comes straight across like that. So that's why when you look at a chest X-ray, it looks like the left hilum is actually higher than the right one. So it's just anatomical. You get a lot of people thinking that it's the heart pushing the left hilum up, but it's actually just doing the vessels in the actual anatomy. So as you can see here, look at your left hilum, this is higher than the right. Now a good sign to look for, which can be quite difficult to see sometimes on chest X-rays, particularly rotated, is looking for what's called the hilar angle. Now the hilar angle is where the upper lobe and lower lobe vessels split. So what you're looking for is you're looking for sort of that appearance there on one side and that appearance on the other side. That there is your hilar angle. So you can see that the left hilar angle is higher than the right hilar angle. They're in normal position. Now, if they're not in that normal position, it could be due to a few things. It could be because the patient's not taking good breath in, that can shift them slightly. It could be that they've got chronic volume loss, so if they've had TB, or if they've had COVID that's then ended up in fibrosis, you can get volume loss and things can shift. But if you have acute collapses, if you've got cancer, you've got interstitial lung disease, that can also shift things. So we'll get onto these push and pull effects a bit later on, but what happens is if you've got a cancer, it pulls things towards it. If you've got a collapse, it pulls things towards it. Whereas if you've got effusions, it pushes things away, but I'll come to that later on. So if you see that this left hilum or the right hilum is pulled up, you've got to be considering, is there a left upper lobe collapse? And we'll touch upon what sort of features to be looking for collapses later on. Now the second rule with your hilum is also looking at the density of them. So this relates to what I talked about the heart. If you have tumour growing or lymphadenopathy around that hilum, you're getting more soft tissue around the hilum. So it absorbs more X-ray, so it becomes lighter. So if you see increased density on one side or the other, you've got to be suspecting, is there something going on there? In that case, you need to be looking at your histories. Is it consolidation surrounding that? So if they've got a lot of consolidation within the middle lobe, it could be that you've got a bit of consolidation just crossing posteriorly behind the hilum. It just makes it look a bit denser. But if you've got no raised inflammatory markers and you see this dense hilum, they're smoking for 25 years, they've got hemoptysis, and you've got to be thinking, we need to be CT in this to look for cancer. Size of them as well is you want to be making sure are they the same size, because again, it might be that what you've got is you've actually got a suprahilar tumour, because if you've got something above the hilum or below the hilum, it's not necessarily going to increase the density, it's going to look like an extension of it. So you're just thinking, is it the same size as it should be as well? So this is where it comes back to getting a good idea of what is a normal chest X-ray in your head, because these sort of things do start to jump out at you. Now, it is sometimes quite tricky with chest X-rays, particularly with people who have pulmonary hypertension and cardiac failure, because you can get quite dense vessels around there as well, so they can be a bit tricky sometimes. But if you've got any queries, then just pop down to the radio department and ask, because the hilar is one of the trickiest areas, I think, on a chest X-ray. And then finally, you want to be working your way further up, into looking into the superior mediastinum, looking at your trachea. Now, if I just get rid of that. So you want to be looking in this region here. This is what's called your paratracheal region. I don't know if anyone's ever heard of that. But the reason you can see this paratracheal region is looking back at the silhouette side. You've got air within your trachea, then got the soft tissue in your mediastinum next to it, and then you've got air next to it. So in between them two air-filled structures, you've got a sandwich of soft tissue. Now this is what a normal mediastinum paratracheal space should look like. Quite thin. If you read the textbooks, it says it should be about 3 to 5 millimeters, but within radio, we don't tend to measure things, you tend to just eyeball it, because it can be affected again by rotation. So a poor quality X-ray can affect all sorts. And this is why sometimes you might have the radiographers ringing you saying, well, there's no way I can get the patient down to the department so they're portable. It's purely because we're trying to get the best image possible to give that more accurate diagnosis. Now, if this is widened, the thing you've got to consider, has the patient got a mediastinal tumour, or have they got mediastinal lymphadenopathy, in which case you've got to be looking elsewhere within the lungs or the abdomen, and the sort of primaries elsewhere. So does that make sense? Okay, so next, lungs, the main thing on the chest x-ray. So one tip I can give you with looking at your lungs is split them up into thirds. It's very difficult for your eyes just to compare one lung to the other lung. It's really difficult. So if you split it down to thirds, it makes it a lot easier. So what I usually say to people when they're starting out is get a piece of paper and just hold it to obscure the middle and the lower zones. So I count it as upper zones being around here, middle zones being from there to there, and then lower zones. So piece of paper to obscure your middle and lower zones, and then just purely concentrate on the upper zones, and you're looking for symmetry in the lungs. Is there any increased density on one side compared to the other? If there isn't, then you know that that's a normal lung. Do the same with the middle lobes. Use two pieces of paper and cover up the upper zones and the lower zones and compare the two. And then also look at your right lower zone, sorry, your lower zones. One area that can be quite tricky, which you may have come across, is this right lower zone, because you get this confluence of vessels that come down. Now with chest x-rays, because we do all chest x-rays erect, just because of gravity, blood always travels down into the lower lobes first. So you get this confluence of vessels that are usually a lot more engorged. So it can sometimes mimic consolidation. It can be sometimes really difficult if the patient's rotated and we've got these engorged vessels to say that there is definitely no infection there. So we tend to might do a follow-up on that one. But looking at the lungs and determining what's going on in the lungs, we'll touch a little bit later on when we come to the alveolar, interstitial disease and everything else. Of course. It varies. It completely depends on our suspicion. So if we get a history that's looking like it's an inflammatory picture or an infected picture, then we'll just do a chest a follow-up chest x-ray, usually in 6 weeks. We tend to use a rule in radiology of so the follow-up is 1 week per decade of life with a minimum of 6 weeks. That makes sense? So if the patient's 60, we do a follow-up in 6 weeks. If the patient's 80, we do a follow-up in 8 weeks. If the patient's 40, we'll do a follow-up in 6 weeks. In patients that are under 30, it's unlikely for them to be getting cancer, so we don't tend to arrange follow-ups for them patients unless we have got a real suspicion of something going on. We might leave that for the referrers to decide clinically has that infection cleared, because we're not doing a follow-up chest x-ray to make sure the infection's cleared. We're making sure that that consolidation has not stayed the same or getting worse, in which case it needs that further imaging. If we look at a chest x-ray and like I said earlier on, they've got 25-year history of smoking, hemolysis, we'll just go straight for a CT scan. But then it depends what sort of CT scan do we do. Do we do a low dose because it's one of them where it might be cancer, it might be infection. So we do a low dose chest x-ray so the patient's getting a full whack of radiation and the contrast. And we can make a decision of that, and then if it is cancer, we can go ahead and give them stages. So there is different ways we approach it. It is just based on clinical suspicion. But this is where as well it really helps if we get some good clinical history from you as well. So as I was saying, this is how I divide my lungs up. Once you get off there with looking at them, you then, if you don't need to use a piece of paper to cover up the chest x-ray, you might get some weird looks when you start sticking a piece of paper in front of the computer screen. So once I've done the lungs, as you can see, I'm working my way out, I now look at the soft tissues. Now, soft tissues are really important to look at on the chest x-ray. You can pick up some quite dense masses in the axilla. One of our radiologists has an area up here called the triangle of doom. So whenever you have any sort of malignancy in the chest, you can get your lymph nodes in the supraclavicular region. You can get increased density in this region up here. But also, if patients had any trauma, it'll help you to decide whether they've got a pneumothorax, pneumomediastinum, anything like that, because you might see some subcutaneous emphysema. If you see some subcutaneous emphysema, it might give you an hint at where there's a rib fracture. So it is really good to look at the soft tissues. Also, don't forget to look below your diaphragms for your pneumoperitoneum. And then finally, look at your bones. So I always look at the posterior ribs first, and then I'll move to look at the anterior ribs because it's just how my brain works. Sometimes, I don't know if on the ward you've ever seen someone turn the chest X-ray onto its side to look at it. This is some technique that even some of the radiologists still use. But the sort of theory behind that is when you look at a chest X-ray in this standard orientation, your eyes are just tuned into looking at the heart and the medial side of the lungs. They're not really tuned into looking at the bones. But when they spin it round, it kind of throws your image interpretation off, so you can concentrate on a certain area. So by turning on the side, it does help some people. Sometimes it doesn't work for some people, but just try it, see if it works for you. But again, you might get some weird looks if you're looking at a chest X-ray on the board like that. So posterior ribs, the oblique down and outwards, as you can see here, and then anterior ribs, oblique inwards. Okay, so you have more posterior ribs visible and you have less anterior ribs visible. You want to be looking for around 10 posterior ribs on a good inspiration and 6 anterior ribs on a good inspiration. So if you see a poorly inspired chest X-ray, you'll see less ribs, but then it can mimic some sort of consolidation. So if you squeeze your lungs up at the bottom, all the vessels and interstitial markings are going to become a bit more crowded. So I've seen quite a few chest X-rays where they've said that there's some basal consolidation, but it's actually just a poor inspiration and all the vessels have been crowded together. So does that make sense? Any questions online? No? And then finally, whilst we're on bones, you want to be looking at the shoulder girdles as well. Now, it's in a few cases where a patient's been referred from ED, following a fall, grade pneumothorax, and they've done the X-ray and they've got a dislocated shoulder. So it's always good to look outside of the chest as well. So look at clavicle, look at shoulder girdle, make sure you've got your humeral joints normally aligned. Are you all okay with looking at shoulder dislocation, what they look like on an X-ray? No? Should we save that for another talk? Okay, so happy with that. That's my way of looking at a chest X-ray. Like I said, it does take some time getting used to looking at it over and over again, and it does seem tedious, but it obviously does get quicker and quicker the more you use it.
Can I ask, as medical students, we also have to present it.
Okay.
So, present the chest
yes.
X-ray, which is why I think the ABCD you traditionally use. When you interpret that, how would you go about presenting it?
The ABCs or?
No, well, how do you do it personally?
So when we were presenting it as part of our training, we went through the system that we used. So it was actually one of the chest radiologists who taught me the inside out method. Fortunately, it was him who was doing our advisors. So when we presented it to him, it was just the same system, so we did it that way. What I'd do is just have a look at your own system, and there's no harm in merging 2 different things together as well, and just use the system that's most comfortable to you. That's all I can advise, because it's difficult when you're learning, because, I mean, the same as when we were learning, is because you get told one thing by one radiologist, another radiologist contradicts it. So I can see when you're with one of your consultants going through a chest X-ray, they want to hear it in the ABC method, but I don't see why you couldn't say to the consultant, I normally do the ABC way, but from what I've read or from my teaching in the past, I prefer to do this way. Is it okay if I do it this way? It's completely up to you how you want to do it.
Can I ask another question? Sorry. When is it appropriate to request a lateral view of the patients?
Rarely nowadays. The reason being is the advent of low-dose CT. So I, every now and again, do request a lateral chest. I'll do a follow-up lateral chest X-ray. The main times I use it is for when I suspect there's any sort of retrocardiac capacity. So a retrocardiac capacity, it could be some left lobe collapse, it could be a tumour, it could be even hiatus hernia. And if they just had a drink or they've had some food, the hiatus hernia can condense, it could look like a tumour. So in them cases, I'll say do a lateral because then it just gives us the answer straight away. It's quick, it's cheap, it's easy to do, and there's less radiation. So in them cases, I've used it. Other times, they tend to just say, just do a low dose. They used to do the laterals mainly for the low positioning. It says so it's in the posterior segment of the right lobe, so they'll know whether it's amenable for biopsy. So nowadays, we don't have to do that many laterals. It's mainly CT scans. So yeah, the low dose CT is, as it says on the tin, it is quite low dose. and it's nowhere near the radiation dose of a full staging CT scan, so that's why we tend to go for them. But I mean, as long as you've got a justified reason for requesting that, then there's no harm in requesting it. So, hidden areas on a chest X-ray. Once you've done your systematic approach, you go back to the chest X-ray and you look at these 5 hidden areas every single time. Anyone got any ideas where the hidden areas are? If you're quick enough, I flashed the first one up on screen by accident. Anyone online want to type in? Yeah, good. So the FCs, that's the first one there. So there was a study that was done quite a number of years ago, and what they did is they plotted on the chest X-ray 10 years worth of data where lung cancers originated. Now the most common location for lung cancer originated was in the right apex. So it's a really good area to always just go back and review, especially you've got your clavicles over in that region. So if you've got any small nodules, they can be hidden and obscured by the clavicles. We had a case recently where there was a chest X-ray that was done reported as normal, which I think if you were to look at it in hindsight, you'd probably say it even still is a miss because it was that subtle. They had a follow-up chest X-ray, I think it was about 6-7 months later, and you could just see the outline of this nodule creeping past the cardiac border, the clavicle border. So it can be quite tricky, that area. Again, particularly for patients who have to be kyphotic. So it's one of the hidden areas.
Yeah, online they said hilar.
Excellent.
Retrocardiac.
Excellent.
Diaphragm.
Excellent. Yeah, so hilar. So going back to what I said earlier on, density, position, and size. Look at them every single time and look at that hilar angle. If you lose this hilar angle on a normal, good chest X-ray, it's nice and straight, you've got to be thinking, is there something going on there? If it becomes a bit bulky, a bit lobulated, you've got to be thinking, is there some hilar lymphadenopathy that's growing around there? Behind the heart, like I said, so this is why you need to have a well-penetrated X-ray, because you're going to be able to see behind that heart. As I said earlier on, you've got to be considering, is it a hiatus hernia? Is it a lower lobe collapse, which I think I've got a case later on, or is it a mass? I'll get to that aortic pulmonary window next, because it's not actually one that's documented in the textbook, but it is a good one to review. But like I said, below the diaphragm as well. Below the diaphragm is very, very tricky, particularly if you've got quite a large patient, because you can't see anything in these extreme lung bases. But if you can see on this chest X-ray, you can see still a bit of elevated lung down here, so you can sometimes see it. We had a case recently where there was a little bulge here, and this was thought to be what's called diaphragmatic eventration. Has anyone ever heard of diaphragmatic eventration? Basically, it's where you've got your fibrous sheet of your diaphragm, and then around your diaphragm you've got all your muscles and your muscle slips. And what happens is your muscles tend to protrude up like that in some patients, so you get this slip of the diaphragmatic slips. So it's cardiac eventration. So that chest X-ray was actually reported as just probably eventration. Patient had chest X-ray 6 months later, and I just saw this getting bigger and bigger. So it was actually a tumour that originated right down in this lung base, and as it was growing, it then actually started peaking above the diaphragm a little bit. So it is a good area to look, but it can be very tricky. Again, particularly for patients taking a lot of good breath in. So can you see how you need to have good chest X-ray to get any sort of reliable diagnosis out of it? So going back to the aortopulmonary window here. So I'll just draw this one for you. So you've got your pulmonary artery coming up over it, and then you've got your bronchus coming down. What can you see how this is sort of concave appears here, isn't it? Now, if you start to get lymphadenopathy growing around all this region here, what's going to happen is going to bulge that AP window out. So what's happening, if you look on this chest X-ray here, can you see how this is nice and concave? But actually it'll be bulging out around here because you've got that sort of suprahilar growth. So I said that's one that's not really documented in the textbooks, but it is a good area to look at. So what do you all think of this chest X-ray? Yeah, good. So if you look at your spinous processes, The distance to the right sternoclavicular joint compared to the left, it is widened, so that is rotated. That is within acceptable limits, that. So think about the sort of silhouette sign and what we've just been talking about, your review areas. So if we look here, normal heart silhouette, then you've got your ascending aorta, which comes up here, loops round, then that's your aortic knuckle, and then that comes down. So you've only got one aortic knuckle. What's this next to it? So you've got a sort of double aortic knuckle sign. Now, thinking of your silhouette sign, this isn't something that's directly next to the aortic knuckle, otherwise it'd blend in and you'd lose this sort of silhouette here. So this is actually a posterior lung mass here. You're able to see that? Now this is actually one where it's not an AP window, because your AP window is actually normal. You see that concavity there. So that's a lung mass. Can everyone see that? And then you can see it here, and it's invading with the mediastinum. Okay, so what do you think of this one?
What was the mass called?
I can't remember off the top of my head. I think they may have just said it was a primary invading mediastinum. I can't remember what's up on that one. What do you think of this one? Good, yeah, exactly. So look at your hilum. If you compare it to that chest X-ray, look at the density of your hilum. So that's your normal vascular density. And then come to this one and look how dense they are. They're a lot bigger. You can't clearly, you can see the hilum angle there, but you can't see it as well on that side. It probably is there, but you've got a bit of soft tissue just next to it here. So yeah, so they've got quite good going hilum lymphadenopathy. Now also, they've got some mediastinal lymphadenopathy. Look, you can see it's winding here. So they've got bilateral hilum lymphadenopathy, mediastinal lymphadenopathy. Any ideas what that might be? Yeah, anything else? Yeah. We've got a third one. Should put a differential in there. So yeah, so this one was actually a case of TB. I think this one was just sent to the chest physicians and they did sputum sample and it came back as positive. Okay, then what do you think of this next one? One more subtle, this one. Yes, there is. It's a good point to look at that because your chest X-ray is nice and central, but it is deviated. But I think in this case, it was actually related to the aortic knuckle. So the ascending aorta is just knocking it onto the side a little bit. So if I was telling you there's a hilar tumour on this, would you believe me? This density here is a tumour. So can you see how very, very subtle hilar lesions can be? It's really, really difficult in some cases. So just look at the density. Look at this density here, and then compared to that, that's a lot brighter. So they ended up doing bronchoscopy on this one. That was confirmed as a tumour. CT and bronchoscopy was confirmed as a tumour. So they can be very, very subtle as well. Okay. So what I want to do now is I'm going to move on to the sort of versus cases. So the first one is earth-based versus interstitial disease. So earth-based disease affects the alveoli. It can be a number of things. It can be blood, it can be pus, it can be cancer, it can be fluid, it can be any sort of other materials. So the primary one you're going to be coming across is pus within it, so pneumonia and infection. So what happens is, if you think about your anatomy, because of the millions of alveoli, it's them that are being filled with the material. So you don't tend to get any sort of straight edges because it becomes fluffy, consolidated, because it just spreads throughout the lobes. It can be lobar, it can be multi-lobar, it can be segmental, it can be confluent, it can involve also, it can have a range of appearances, so that's when it gets a bit tricky. So also what you can see is you can see bronchograms sometimes, which you can just see on here. So bronchograms, think about it, alveoli come with the materials. That means there's no gaseous exchange that's occurring. As we take our chest extra inspiration, the breathing, the bronchi, the bronchioles all come over there, but it's not going to escape anywhere because they're holding inspiration. So these bronchioles expand with air, and then what you see is the tracks of air through areas of dense consolidation. Have you ever seen anything like that on a chest X-ray? Looks like you get these like tram lines through a dense white out. You may not do, but you may see it more. I think we have got another case of it later on, which it shows a bit better. But obviously, as they exhale, all that air will expel, and then you'll just get a big dense blob again because you won't see them bronchograms. Sometimes you can have pleural effusions associated to it, so you have paraneuronic effusions, you have an empyema. So if you're looking for an empyema, you might see a loculated pleural effusion. I haven't touched upon pleural effusions as much in this presentation, but in a nutshell, if you have a standard pleural effusion, it'll tend to accumulate in the bases. If you've got a complex or a loculated pleural effusion, you might see it just adhering to this wall here because it's become a bit sticky, so it'll stick to the side of the wall there, and you'll see it just on the side, and you may not necessarily see anything in the lung bases. Now moving over to interstitial disease. So interstitial disease is actually a disease within the scaffolding of the lung. So we all heard of the interstitium of the lung. So your lungs are built up by sort of polygonal structures within it. So if you've got all these polygonal structures within your lungs, so what happens is, this is all the interstitium here. If you get infection within the interstitium or some chronic disease within the interstitium, whether that be sarcoidosis, rheumatoid, or just standard ILDs, and all those ILDs, is these lines become inflamed. And you also get it within pulmonary edema because you get the fluid accumulation within the interstitium. So they become wide, but as you can see, as more and more of these build up, you get all these sort of straight lines. So has anyone ever heard of curly bee lines? So curly bee lines, particularly seen in pulmonary edema, and that's what you'll get, is you get them straight lines that emanate from the periphery of the lungs, typically within the lung bases. So that's the sign of fluid within the interstitium. There are other times when you'll see curly bee lines. If you've got carcinomatosis, lymphangitis, then you'll see it in the Yes, yeah, you will do. So you want to be looking in the lower zones, peripheries, and then also if you've got the other signs of cardiac failure, so the other signs of cardiac failure on chest X-ray. So, yeah, good. So cardiomegaly first off, effusions, and then upper lobe venous distension. So as your heart starts to fail, instead of all that gravity pulling down, it starts to fail, and it pushes it up and really diverts it up as well. So they're the sort of triad of findings for cardiac failure. Cardiomegaly, upper lobe venous distension, and bilateral pleural effusions typically. I have seen cases where you have a unilateral effusion. Because what you've got to remember at chest X-ray is to actually see pleural effusion on a chest X-ray, you need to have about 270 mils of fluid actually in your lungs to be able to appreciate it. So you imagine that's a mugful of fluid actually within your lungs to be able to see it before you see any sort of blunting. So in cardiac, you could have quite a lot of fluid in one side and only a very little bit of fluid in the other, so that's why it might give that impression that you've got a unilateral effusion, but they might have bilateral, you just can't see it. And so that should feature the cardiac failure. Then when you come to your pulmonary edema, you want to be looking for your Curly B lines. So your Curly B lines is the sign of interstitial pulmonary edema. But obviously once that interstitium reaches threshold pressure, it will then start to spill into the alveoli. It then becomes an alveolar process and you'll see the consolidated picture. I've got a better case of it later on. But I don't, it's quite small though, so you can't really appreciate them, but there's sort of some here. But I have got a better case of it later on that's blown up as well. Okay, the hot topic, I'm sure you've all seen many of these chest X-rays. So, you're probably aware by now, the typical features of COVID-19 on a chest X-ray are peripheral predominance, bilateral, mid and lower zone consolidation. It can be patchy, it can be confluent, and by that I just mean you've got multiple areas of consolidation that are joining up together, and you don't tend to get pleural effusions. I have seen quite a number of cases now where the patient's been confirmed COVID positive and you've only got unilateral presentation, or they have got pleural effusions. So yes, there are, use them loosely, but the predominant feature is, like I said, bilateral, mid and lower zone, peripheral consolidation. I believe you don't tend to get high lymphadenopathy, so any reactive lymphadenopathy with COVID, from what I've been told. So there's just two chest X-rays here. So you can see here, they've got its confluent consolidation, so you've got its patchy, ill-defined consolidation here and here, and then some here. We can see the predominant features, it's based in the edges of the lungs. Can you all see that? And then no effusions. These cross-link angles down here are nice and sharp. On the other hand, this patient was also confirmed COVID positive, and they've got a completely normal chest X-ray. So we can't rely on the chest X-rays to rule out whether they've got COVID or not. So what I wanted to... Yes, yeah, they are that, and then a PCR, and that came back as positive. So what I wanted to do now is I just wanted to show you a series of chest X-rays going from pre-COVID through to post-COVID. I thought it was just a good set of images that I came across. So this was a patient pre-COVID. Yeah, they've got some background chronic changes in the lung, but essentially there's no acute consolidation within there. There's no fluffy ill-defined consolidation. There's no bronchograms. There's no pleural effusions. This opacification down here is probably just due to breast shadow overlying lung bases. They then came in, I think it was around February time, if I remember correctly. And can you see the dramatic difference in the chest X-rays? They've got this sort of extensive, widespread consolidation with sparing, particularly this left apex, but the rest of the lungs have got some consolidation in there. No pleural effusions again. It then gets worse. And can you see how it's then progressing more to the peripheries now? It's really, really dense in these peripheries here. So this was June, this was July, and then that was a CT, just so you've got an idea of the CT appearances of it. Peripheral predominance, minimal zones. And then this is the patient on the other side of it who's coming down. So you can see that the bulk of this consolidation has progressed, but there is still some residual change. But then it's starting to fibrose down now, and again, this fibrotic scarring in the lungs. So there are going to be some patients who the lungs are really, really bad after the COVID infection. Like I said earlier, I think prior to actually doing the talk, there are some where the lungs completely clear afterwards, but there are quite a few cases where they become fibrotic. And as I said earlier on, it's saying now that COVID is actually accelerating in the ILD that they have. So it's one thing you're really aware of. Okay, so what do you think of this chest X-ray? COVID. So there's ill-defined consolidation in the mid, lower zones, no pleural effusions. Yes, it's not got peripheral predominance. What would you be thinking? Would you be thinking COVID? So yes, it could be pneumonia. I want to scare you a little bit now. This is actually TB. It was reported as COVID, but it actually came back to see it. Now, it is an atypical presentation of TB. So TB in your chest, you tend to get apical changes first. You'll get the consolidation of your apices. You'll get lymphadenopathy. You might get mediastinal lymphadenopathy. And so that was why the reporter went more towards COVID, particularly in the current climate. But it ended up coming back as TB, that one. So the reason I put this one in, just to show you that you can have pathologies that mimic each other. So it can be really difficult in some cases. So if you get a chest X-ray that doesn't really match your clinical suspicion, you've got to treat your clinical suspicion rather than the chest X-ray. Okay, so looking at effusions and collapses. So has anyone ever seen a white out of a lung other than two images on screen right now? Yeah. So we were able to confidently say whether it was a fusion or a collapse. Did you have the patient or the patient's history in front of you?
It's difficult because in infusion, like, it's only like half.
Right, okay then. Right.
It's easier.
So when you have complete whiteout of the lung, it's very, very difficult to say whether that is complete collapse of the lung or whether that is just a huge whiteout because they've got so much fluid in the lung, it's just completely filling the lung. Now, there are signs you can look for. Remember earlier on when I was talking about the sort of push and pull effects? If you have lobar collapse, well, what happens to the trachea? Which way? Exactly. So yeah, so it'll pull it towards the collapse. So if you look on this side here, you've got complete whiteout of the lung. And what happens is it pulls the trachea across, but also where's the heart gone? You cannot see the heart shadow at all. It's been completely pulled across. So that's how you can tell whether something's lobar collapse. Conversely, pleural effusion, what's happening is that effusion is filling the lung with the pleural space, it's increasing the volume of the thorax, it's going to push things away from it. So trachea will deviate away from it. So you can see more of the heart on here. Now, other things you can look for as well is you can look for widening of the inter-rib distance. So if you've got something that's increasing the volume, it can sometimes just push your ribs away a little bit, and you might get, this is a case of it here, but you might get widening of your rib spaces. So if you compare it to a previous chest x-ray, you might see that widening. So it's always good to look at the previous chest x-rays in every situation. If you get volume loss in the lung because of a collapse, it might pull your ribs together and become a bit more crowded. Now, moving on a little bit further, this is a bit more of a radiology sort of finding because you guys will have the history. But how do you tell between a pleural effusion, a lobar collapse, and a pneumonectomy? Because when you guys become radiologists, you might just get a request to just say short to breath, and you've never had any other imaging within radiology on our side, and you get this appearance. How do you know that that's a pneumonectomy?
Will it not have any?
It does have tracheal deviation, yeah. This is where it gets tricky. So yeah, so it has tracheal deviation towards the abnormal lung. So now that's got rid of it being pleural effusion. So now we're at, is it lobar collapse or is it pneumonectomy?
I might be wrong, but in the pneumonectomy, you can still clearly see the trachea.
Yeah, that's probably just due to the actual projection. This patient here is quite rotated, so you might be obscuring the trachea a little bit because of the rotation.
Someone online said about seeing fissures.
In the collapsed lung, you might not see fissures because the fluid that fills up the pneumonectomy space, you hide things, and if they've had a pneumonectomy, you don't have any fissures there anyway.
It's that a lot, right?
Here, so that is going to be a bit of bowel. So when you get volume loss, is because of the volume loss, your diaphragm shifts up. So anything below the diaphragm will also move it with it. So you might see a high riding stomach bubble, but that's again the case in a lung collapse and pneumonectomy. Look for surgical flips. As simple as that. Just think logically as well. So there's surgical flips in the high lung as well. So that is all you can really look for. It's very, very tricky sometimes. Can you see this thing, little slightly increased density? Yeah. I know it would be better if you had a full-blown pack monitor in front of you. So, but yeah, so yeah, you won't be looking for any surgical clips. But hopefully, you're going to have a better history than just SLD. You'll have some sort of history, but it can get quite tricky. I mean, in some cases, well, you might just pick the phone up and speak to the referrer. That's what I tend to do. Okay, so that makes sense. So lobar collapse, there's whenever a lobe collapses, it has its own sort of characteristic findings, and this is where the silhouette sign really, really helps. So your lower lobes, both lower lobes abut the diaphragm. So if you have any sort of lower lobe collapse, you will lose the definition of the diaphragm. If you have a right middle lobe collapse, that abuts the cardiac border, so you will lose definition of the right cardiac border. However, both upper lobes, they don't really have an interface with any structures, so you get a bit of different appearance with it. So looking at right upper lobe collapse, what happens is the lobe collapses upwards and forwards. So the hilum will be dragged up with it. So it's the same sort of effect as I was talking about earlier about the total lobe collapse. It will drag things towards it. So here's the left hilum, but then looking at your right hilum, it's actually higher up this time. It's up here. You can see the hilum angle around here. So it's pulled up. And what's also happened is the fissure's been dragged up. This is actually where the fissure lies. So as it drags up, it becomes more collapsed and consolidated. So that's why you get this white, this sort of whiter appearance up here. Now this was actually due to a tumour in a hyalotumour. This sort of appearance has a name as well. It's called the reverse S sign of Golden, which is just a radiographic description for it. So we'll talk about the reverse S shape you get there. So it's upper lobe collapse with a hyalotumour. And also, can you see how the trachea is pulled towards the collapse? Yeah. What do you all think of this? So this is actually unfolding of the aorta, which is then exaggerated by the rotation. So you can see that they're just spinous processes. Look how far away from that sternocleidomastoid joints. So they've got a bit of an unfolded aorta. It's then rotated that way. It's exaggerated it more. So you've got to be careful these aren't interpreted as mediastinal masses. Now looking at a left upper lobe collapse, what happens is, if you heard of a veil appearance, so with your lobes, if you look at a lateral, so that's your lateral left lung, and you've got your fissure like that. So what happens is the left upper lobe collapses forward and then up a little bit, but so that becomes denser. But you've still got aerated lung behind the upper lobe. Does that make sense? So what happens is you get that veil appearance because you get the increased pacification of the upper lobe overlying the aerated lower lobe. So that's why you get that appearance. Now, what you can actually look for as well in left upper lobe collapse is you can look for this sign around the aortic knuckle of just normal air. Now, what this is actually herniation of the aerated left lower lobe just coming in front of the upper lobe. It's called the Lussicial sign. So if you ever see this sort of veil-like appearance, you see a bit of volume loss, because you might not see a lot of volume loss because the left lower lobe is the bigger one. Look for this sign around the aortic knuckle as well. And that can indicate that it is left upper lobe collapse. Consolidation versus cancer can be very, very difficult when looking at these because you can have focal area of consolidation that can mean it's infection or cancer. So looking at these two here, you've got this sort of spiculated consolidation in the left midzone here. And then on this side here, you've got this peripheral lesion. There's a bit more well defined in the right midzone. Which do you think is cancer and which do you think is consolidation? That's your consolidation, and that's cancer. So if you think that essentially could just be a larger version of that, when we talk about cancers on CT, we talk about them being spiculated. You could argue that that is spiculated, so why is that not a cancer? Well, the reason is because we did follow up on both of these. So I think they were both reported as originally as inflammatory. They did a follow-up of this one, and after antibiotic treatments, it came back as completely clear. This one came back, and it was exactly the same after 6 weeks, so straight CT and it was confirmed cancer. So the take-home message of this one is very, very difficult when you're trying to determine between cancer and consolidation, unless you've got a strong history of smoking and everything like that, and hemoptysis. So we always do the follow-ups to determine what course of action we need to take. And then obviously that's your CT scan there, you can see the mass. Okay, what do you think of these? Is it consolidation? Is it cancer? Or is one consolidation, is one cancer? So looking at the left-hand image, dense, consolidated picture in the right upper lobe. I can confidently say it's in the right upper lobe because it's a butt in the horizontal fissure. If you remember earlier on I said that when you have consolidated, it doesn't tend to form straight lines because of the fluffy alveoli. But when it abuts a fissure, you will get a straight line, so it can't go past that fissure. So you've got a well-defined edge. Looking on your right-hand image, grand glass sort of appearance, consolidation in the right lower zone. Are they both pneumonia? This is just a bit of a more advanced case, is it? No. This is consolidation. This is cancer. So as I was saying earlier on, one of the things that you can get accumulated in your alveoli is cancer cells. So bronchoalveolar cell carcinoma in situ. That's exactly what that is there. So again, this is one where it's really good to follow up. So this one here, they came with more inflammatory clinical history. So we said, right, just do a chest x-ray. The follow-up chest x-ray came out completely clear. Now this is a good one here, because can you see the bronchograms? Can you see these lines coming through here? I don't know how well it projects on screen, but there are some bronchograms in there. Now on this one here, this one came with smoking history, hemoptysis. They had a cough for a few months. Also, this infrahilar region here didn't look very good. So we ended up doing a low dose CT on this person, and that came back as cancer with hyaluronopathy. And then that was the CT scan there. It's confirmed PCO this tumour. Bronchoalveolar cell carcinoma in situ. It has got a different name now, I believe. Adenocarcinoma in situ, I think it is now. Yeah. Okay. So these are two chest x-rays that were taken through our ED departments. Which is a pneumothorax? Which is a bulla? Or are they both pneumothorax? Have you seen quite a few pneumothoraces now within your training? No? Okay. The other way around. Yeah. So your left is pneumothorax and your right hand image is your bulla. So pneumothorax, I don't know how you guys get taught to look for pneumothorax. As radiographers, when you're training, it's just say, look for absence of lung markings in the peripheries of the lungs. Now, the issue with that is that in young patients, where you're primarily getting pneumothoraces, because the lung markings, as they get towards the edge, become so thin that the x-rays can sometimes just pass straight through them. It looks like there are no lung vessels there anyway. So what you want to look for is you want to look for a defined edge, and then distal to that, you don't see any lung markings. So what you're seeing there is you're seeing that pleural layer. You're seeing the visceral layer of the pleura, and then you're seeing an accumulation of air in between the pleural space. So can you all appreciate that on your screen? You can see the visceral pleura there, and then you've got no lung markings at all. Now, usually that visceral layer will parallel the chest wall. But bear in mind, most pneumothoraces, as air rises in the AFCs, you can have loculated pneumothoraces as well, particularly in patients who have had any sort of pleurodesis or anything like that, or they've had any sort of intervention. You can get loculated pneumothoraces, so you might see them lower down. Now, bulla, on the other hand, is they're within the lung, and what happens is they expand out and they actually give you a concave border like they do here, so they don't parallel the chest wall. Now, this is a case that was actually thought to be by the ED staff that it was pneumothorax and they stuck a drain in that. So it is really important that you're able to differentiate between pneumothorax and a bulla. Another thing to look for with a bulla is the margins of it. So yes, you're going to have that concave margin, but it also is a little bit thicker because what's happening is the bulla is squashing all the lungs surrounding it. So you get a little bit of a thicker white line around it, whereas when you've got that pleural layer, it's very, very thin. Now, other thing as well, hopefully you'd have a previous chest x-ray. If someone's got emphysema this bad, more than likely they've had a previous chest x-ray, so you can use them to look at. And the final slide of the presentation is extrathoracic pathology. So what do we think of this image here? Exactly. So as I was talking about earlier on, always look in your shoulder girdles because you can see they've got a left glenohumeral joint dislocation. So typically, if you look at your right one here, it should be sat within the glenoid, but on here it pops out and it's slipped in just underneath the coracoid. So that's an anterior subcoracoid dislocation. This was a patient who fell in ED, one I was talking about earlier on. Patient fell in ED, they came with pneumothorax. I think the patient had dementia, so we weren't able to assess it properly, and then came back as that. So this shoulder views and this is an acute dislocation. I'm just thinking this image here. Exactly. Yeah. So the story behind this one came through, and it was actually reported as a pneumomediastinum. It's not. I put it in there because it's what a pneumomediastinum would look like, but it's actually a loop of bowel. So can you see this bowel coming around here? It's just a bit smooth, so you can't see any houseful folds in it. But this is what's called Chilaiditi's syndrome. So if you see air underneath the diaphragm, but you're not clinically suspicious of pneumoperitoneum, then it might not be. Also, if you've had previous surgery, abdominal surgery, it could be free gas. If it's not, it's going to be as well. If you've got any concerns, no. Your coffee bean sign you tend to see more down in the sigma. Now don't quote me on this because I don't report abdomen x-rays, but your coffee bean sign is more to do with sigmoid volvulus, so you tend to see a bit more inferiorly than the abdomen x-ray. So that's the end of the actual presentation. We're 8 minutes over. Did we have an hour for this, or are we okay to carry on? Everyone online happy to carry on going? So we've got 11 x-rays here that we're going to go through together. So what do we all think of this chest x-ray here? So if I start off looking at my system of approach, look at my heart. So remember earlier when I talked about the heart looking a bit triangular? We all know that your heart is not a perfect triangle like this one looks like. So this is actually pericardiac fat next to it. So if you look at this density here, this matches the density of here, doesn't it? We know this is all fat. So we can say that that's pericardiac fat. So the heart is normal. Coming further up, the hilar are of the same density bilaterally. Yes, you can't see your hilar angle as clearly there, but you can see it on here. It's in a normal position. The left is higher than the right, so I'm not too concerned about any hilar pathology. Working my way up, trachea is nice and central. The right paratracheal region is nice and smooth. This patient's quite a large patient, so you can get mediastinal fat sometimes. So that's probably why there's a bit of extra soft tissue around here. But now coming off this other side, there's a bit of an abnormality here, isn't there? This should usually be clear in this region. So there's something going on there. So that was reported quite correctly as increased pacification, left apex. Did a low dose CT scan to start off with, and that was a paraspinal mass. So we can tell that it's in the lung because I can still see the aortic knuckle superiorly, so we know that's in the lung. Okay, next one. Just think of this one. Yeah, good. I'm sure you think he's not really something that simple. So one thing with chest X-rays is the other satisfaction search. So satisfaction search relates to once you've seen one abnormality, you forget about everything else and you focus on that one abnormality. You've got to try and get out of that habit. Once you see one abnormality, bank it, look at the rest of everything else, and then go back to it. So yeah, you've identified this sort of dense opacity in the right mid zone, but I'm going to ignore that now and I'm going to look through the rest of the lungs. So I'm going to cover up my mid and lower zones, I'm going to compare the AFCs and then look. There's an increased density there, which there isn't there. So remember when I talked about clavicles hiding things, this is a good case of it. So there's actually 2 lesions in the lungs here. So I think this one came back as that was the primary with a net in it as well, that one. So it's just a good satisfaction search one. So like I said, any abnormalities, you see it, bank it, look at everything else and go back to it. And it's the same when you're looking at MSK as well, because a lot of time with fractures is you're going to have a few fractures. So see the fracture, ignore it, look elsewhere, and then go back to it. Okay, what do you think of this one? Bit of a tricky one, this one. So if you ignore the highlight, the highland. Have a look at your lungs. Split your lungs up into thirds. Is there any abnormality on one side that isn't evident on the other side? Left mid zone.
Kind of like white bits.
This here.
Further down.
Here.
Up.
Here.
Take that.
Oh, so right. So that's the hilum. So I think that's a normal hilum. Appears. Yes, it does look a little bit denser. We'll get to the reason why it looks a bit denser. But
Someone's put right lower zone.
good. So yeah, so there's some right lower zone consolidation. So seen an abnormality, bank it, look at the rest of the X-ray. Good. So can you all see this up here? All this thickened pleura in this apex that isn't comparable to the side. So if you have biapical pleural thickening, you can look at previous chest X-rays and it's probably been there for a long time. However, when you have unilateral pleural thickening and the textbook say it's greater than 5 millimeters compared to the other side, you've got to be a bit concerning. So this was actually Pancoast tumour. And the reason that this was a bit denser is because they had a bit of mesanopathy. So yeah, and then this was just some incidental consolidation. So again, always look in your right apex and compare the 2 sides. Okay, moving on.
That's scoliosis.
I wouldn't call it scoliosis. They've probably got a mild curvature of the spine. So the class of scoliosis has to have a cob angle that's over a certain degree. So with that, you might have said minor curvature.
Someone's put left apical pneumonia.
Apical pneumonia. Really? I was going to force the left apex in line. There's actually a pneumothorax. So can you see that very, very thin line there? And then distal to that, there are no lung markings whatsoever. So can you see here, there's all these lung markings, and I just come past that, it's just very black. So they've got a left apical pneumothorax. Now, actually, you might not be able to see it on your screens, but it actually comes all the way down here. So I still don't think that's did stick a drain in that. I think it's too small because when I spoke to the ED, they said that it has to be about 2.5 centimetres at the level of the Highland to put a drain in it. So I think they just treat that conservatively. Okay, next one. Think of the lungs. It could be, but no, because you can have that sort of appearance with interstitial disease when you get. So with interstitial disease, you can have what's called reticular shadowing, which is lines, so the curly lines. You have a nodular shadowing, which should be like this. So with nodular, you kind of think, if I could get some tweezers, I could pick little nodules out, that's a nodular. But kind of a mixture of two. So yes, you can have a nodular interstitial disease pattern, but this isn't actually. So this isn't sarcoidosis, but sarcoidosis, you do get nodular changes. This is the reason why I put this one in. So yeah, so miliary TB, it would actually be a lot small. You get tiny, tiny dots. There's loads of them. So it's just referring to miliary seeds. They're so small, that's why it's called that. So these are actually a bit too big to miliary TB. They're also a bit too dense. So if they're a bit too dense, they're more likely got some calcification within them. So the fact that they're quite dense, this calcification tells me it's been there for quite some time. I look back at a previous chest X-ray from a year ago, looks exactly the same. So this is actually old chickenpox pneumonia that's calcified down. So it's quite a typical pattern. So you want to be using your previous chest X-rays. And that's the one thing I just strongly advise always. As soon as you pull up a chest X-ray, load up the previous chest X-ray next to it. Okay, what's into this one? Yeah. So this is just normal Highland, but it's AP, so your AP projection makes it look worse, but it's just normal Highland now. If you look at the density between that and that, they're exactly the same, aren't they? And you can see your Highland angle here quite clearly. So that's just Highland. You have also then got your scapula overlaying it. No. So with the pleural effusion, can you see on this side here, where you haven't got that sharp costophrenic angle, there is a small effusion on the left here, because you haven't got that crispness of it, so there is a fusion there. On the right, unfortunately, there isn't, no. You're in the right region, looking at this here.
I don't know what that is.
Yeah, yes, so right in the diaphragm area, sorry.
It's got like a irregular shape.
What, are you looking at this region here?
Yeah.
Yeah. So this is actually Chiliditis syndrome, which we talked about earlier on. So can you see these are your haustral folds? So what's happening there is you're getting the bowels sort of being interposed between the diaphragm and the liver. And it sits there. So again, I just wanted to put it in just to make you aware of it. It isn't pneumoperitoneum. But yeah, the chest X-ray other than this little pleural effusion, normal. Okay, what do you reckon to this one? It's not, you're on the right track. It's not really globular because you've still got this sort of concavity to this part border here. If it was globular, it tends to bulge out a bit. You get a water bottle sign, so it tends to bulge out a lot more around here and then comes up. And actually, it's not that dense. This is one where the X-ray exposure is not the best. You're on the right track, though. there's no obvious effusions, but I imagine they will have some. You just can't see them. So I said earlier, look how sharp that cosmetic angle is there. And on this side, they're really sharp, so there's no blunting in it, so there's no fluid that we can see on there. Exactly, perfect. This is one I've titled Cracking Curly Bee Lines. Because can you see all these lines that are emanating from the peripheries of the lungs? So that's just a really good case of curly bee lines. So that's just the interstitial edema accumulating in the interstitium. You can see it there. Okay, a bit more subtle. Just into that. So when I was doing the systematic review at the beginning of the session, so one of the areas that it can be quite helpful in some cases is soft tissues. So concentrate on your soft tissues and can you see any abnormality? Exactly. Brilliant. So in the left supraclavicular region. So we've got subcutaneous emphysema. So what can that indicate? Of course. So you see this here. So this is all subcutaneous. Compared to this side, there's nothing here at all. But then you've got this area underneath the soft tissues there. So subcutaneous emphysema, it could be coming from pneumothorax, and we've got a penetrating wound. It could be coming from a pneumomediastinum, or it could also be coming from pneumoperitoneum, so it can travel straight from the mediastinum and go into the neck. So we know there's three things now we're going to be looking for closely for. So do we think there's a pneumothorax? So let's have a look at the lung markings. You can see them coming all the way out to the edge. Yes, you can't see any on this side, but the free gas on that side. So we're confined to this region, and I can't see any pleural line. So there's no pneumothorax on that. So the next thing to look for is pneumomediastinum. Is it coming from there? Now, look at your mediastinum. So first off, look at your heart. It's the first area I always look at. Nice heart body, bit of air, and then what's this? You've got another very thin line there, and that line you can actually follow all the way up. Can you all see that? And you've got a bit on this side as well. So what you've got is you've got trachea, you've then got a bit of soft tissue, you've then got air, you've then got another line of soft tissue, then air. That's not normal. So this patient's actually got pneumomediastinum. So these can be extremely subtle. So I think this patient, this actually wasn't a trauma perforated esophagus or anything like that. It was just patient presenting with chest pain and they've got non-asthma. So they've got non-asthma. So asthmatic patients can get pneumomediastinum. Just treat it conservatively. I think we came back a week later, a chest x-ray and it completely cleared up. Okay, next one. So hyperinflation, when you're looking for it on a chest x-ray, is you want to see more than 10 posterior ribs, and you also want to see flattened diaphragms because it pushes the diaphragms down. So we've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. I can clearly see 10, and the diaphragms aren't pushed down, so I don't think the hyperinflation, they're probably just taking a good breath in that way. But yeah, you're right, it's always good to look at for the hyperinflation in the lungs. It's a tricky one, this one, but pneumothorax. Very, very subtle pneumothorax. They're not going to treat it, but again, look towards the edges, see a pleural line, and then distal to that pleural line, there are no lung markings.
this is so far from the house.
Yeah.
So can you show us where they were measured?
Yeah, of course. So what they do is, when they say measure from the Highland, I always choose the Highland angle to go from. So I look for my Highland angle, which is here. So I can see that triangle there, so I know it's there. All agree? So then I work my way out to the edge, and you want to follow, it's because it's such a small one, it's difficult to see, but you'd see this pneumothorax, this pleural line, extending all the way down. So you might see it come round, and in some cases it will come all the way down to the cosphenic recess. And then what you want to do is you want to measure that distance there. So the distance from the pleural line to the edge of the chest wall. And if that measures more than 2.5 centimetres, that's when they'll start thinking about draining it.
That's when you measure from the level.
At the Highland, yeah. If it was on, if it was on the other side, obviously it'll be a little bit lower down, so you measure it around there. Yeah. Okay, next one. Excellent. Look at this. Yeah, exactly. So if you think back to what a normal chest X-ray looks like, you've usually got a nice clear periosteal stripe. There's no bulge in this region. In this region, all you should really be seeing is SVC, azygous vein, but you've got definite bulge in here. And this is actually a bit widened here, so this is a mediastinal mass. Yeah, excellent. Finally, this is one I reported today. I thought I'd chuck it in because it's a subtle one. It's a good teaching point. So you can see the quality of that X-ray is not the greatest, is it? You can see how dark the lungs look. So when you get really dark lungs, it could be one of two things. It could be that they've got hyperlucent lungs because they've got COPD, or it could just be the exposure. I think this one's more the exposure. No. Are you looking down here? Yeah. I think this is just breast tissue overlying the lower zones. No. Look at the density, they're very, very similar. They're in the normal position, they're a normal size. It is a subtle one, this one. So, can you all see this here? Can't really appreciate that well. But there's, if you look, if you can try to draw around it. Can you see that? Yeah. So there is some opacification in this left upper zone. Now, I reported this as a pleural base mass because I can tell it's pleural base because of this obtuse angle. Think about if you had a lung cancer that was growing from a central point out towards the edge of the lung, you'd get an acute angle as it hits the pleura because that's trauma. If you had a rounded mass, because they grow from the centre point, so they'll grow from the centre point and they grow out, you get that acute angle. However, this one has this obtuse angle, so that tells me that it's actually something growing out from the pleura into the lung. So I just thought, because you don't see them that often. So we've sent that for a CT scan and find out what it is. So the first is we've done a low dose on that one just to make sure it is definitely a pleural based mass. And then if it is, we'll go on and do a staging. Not too sure. Low dose because this patient had only the chest X-rays, so it could be just a benign lipoma as well. You can have pleural lipomas, which have this characteristic appearance on CT scan because on the lung windows you can see them. But as soon as you change it to the mean standard windows, they vanish. So it's a good test to do first to see whether it's clear light building or not.
Right.
And that's it. That's all I have for you.